This video will demonstrate the provocative physical examination techniques used in diagnosing sacroiliac joint pain. The sacroiliac joint, or the SI joint, serves as a link between the axial and appendicular skeleton. In this role, it transmits and dissipates the force created by the truncal load to the lower extremities. Reports as to the prevalence of SI joint pain are highly variable, ranging from anywhere between 10% and 62%. Overall, a prevalence of about 25% is most commonly reported. A number of factors make the SI joint particularly vulnerable to injuries caused by high stress and strain. First, only the anterior third of the joint is a true synovial joint. The rest is composed of complex ligamentous connections that serve to limit the motion of the joint, and the posterior capsule is largely absent. Furthermore, the vertical orientation of the joint increases the shearing force, particularly in the limited anterior area. Clinical examination in cases of suspected sacroiliac joint pain begins with evaluations of gait, leg length inequality, and the lower lumbar region. It is always recommendable to request the patient physically indicate their pain's location to avoid miscommunication due to an inaccurate anatomical understanding on their part. Hip pain may be ruled out using range of motion examination, including internal and external rotation and the Trendelenburg test. Sacroiliac joint-specific tests may be employed once other likely pathologies have been ruled out. However, these tests are reported to have wide variation in both sensitivity and specificity. Furthermore, their negative predictive value is much higher than their positive, and as such, they are generally more useful for ruling out sacroiliac joint pain than for diagnosing it. If 3 or more sacroiliac joint-specific tests, along with the Fortin's finger test, are positive, then a sacroiliac joint contrast-enhanced injection under fluoroscopic guidance may be indicated. This injection is much more useful from a diagnostic standpoint, with a specificity of 83% and a positive predictive value of 93%. Recommended provocative tests for the diagnosis of sacroiliac joint pain are the Faber, or flexion abduction external rotation test, the gapping test, also called the distraction test, the compression or approximation test, the thigh thrust or femoral shear test, the Gainsland or pelvic torsion test, and the sacral thrust or sacral base spring test. These tests will now be described and demonstrated. In the Faber test, the patient is placed in the supine position and the foot of the test leg placed on the knee of the opposite leg. The knee of the test leg is pushed towards the table. The opposite side may be stabilized to maintain a neutral position of the lower back. A positive result is indicated when the exact pain is reproduced while the test leg's knee is above the opposite straight leg. The sensitivity, specificity, reliability, and positive and negative predictive values are shown here. In the gapping or distraction test, the patient is placed supine with the affected side close to the edge of the table. The examiner then applies pressure to both anterior superior iliac spines in the dorsal and lateral directions. The values associated with the gapping test are shown here. In the compression test, the patient is placed on their side with the affected side up facing away from the examiner, with their hips flexed to about 45 degrees and knees flexed at 90 degrees. The examiner places both hands over the lateral prominent iliac crest and applies a downward pressure. The values associated with the compression test are shown here. In the thigh thrust test, the patient is placed supine with the test leg on the side of the examiner. The contralateral leg is fully extended and the ipsilateral leg flexed 90 degrees at the hip. The examiner slightly adducts the femur and, while cupping the sacrum with one hand, wraps the other arm and hand around the flexed knee and applies a graded force through the long axis of the femur. The values associated with the thigh thrust test are shown here. In the Gainsland test, the patient is placed supine with the test leg lying over the edge of the table. The contralateral hip and knee are flexed towards the chest and counter pressure, causing hyperextension, is applied towards the floor to the hanging leg. If necessary, the pelvis may be stabilized by an assistant. The values associated with the Ganslin test are shown here. In the sacral thrust or sacral base spring test, the patient is placed in the prone position and the examiner applies a pressure vertically downward on the center of the sacrum. The values associated with the sacral thrust test are shown here. If 3 or more of the diagnostic sacroiliac joint tests are positive, there is between a 65% and 93% probability that the pain is originating in the sacroiliac joint. The negative predictive value for 3 tests is 87%, and the positive predictive value is 77%. This is significantly higher than the low specificity and 59% positive predictive power with just 1 positive test. If less than 3 diagnostic sacroiliac joint provocation tests are positive, then there is a 72% to 99% probability the pain is not related to the sacroiliac joint. Thus, it is important to perform at least 3 of the previously described SIJ diagnostic tests to significantly improve diagnostic capability. Several studies have described difficulties associated with the use of provocative sacroiliac joint tests. One is the extremely limited range of motion in the sacroiliac joint, such that it is difficult to reproduce clinically the natural motion of the joint. This is caused by the anatomic confinement in the surrounding ligamentous and muscular structures. Another difficulty is the inability to distinguish intra and extra-articular pathologies with numerous potential pain generators in the surrounding extra-articular area. In conclusion, provocative physical examination tests of the sacroiliac joint are more effective at ruling out SIJ pain than confirming it. In cases where SIJ pain is suspected, particularly when 3 or more positive provocative examination maneuvers are noted, a fluoroscopically guided injection of the sacroiliac joint should be considered to confirm the diagnosis. This injection is associated with a 93% positive predictive value compared to the 77% positive predictive value of the physical examination maneuvers alone.